Yeah.
Okay, so while Julie does that, Peyman, you're going to be the first to present. So I will announce you, and then when you're done, I'll announce Morgan. So our first presenter today is Peyman Mehrabi, who is currently an MScN student, and he is mine and Dr. Kelly Lackey's student. So Peyman will be, his presentation will be called Internationally Educated Nurses, Emotional, Behavioral, and Cognitive Responses to Workplace Integration in High-Income Countries, a Scoping Review Protocol. So Peyman, whenever you're ready, please feel free to share your screen and start. You just unmute, Peyman, in case you didn't know.
Can you hear me now?
We sure can. Thank you.
Okay. So, hi everyone. My name is Peyman. I'm an internationally educated nurse. I'm currently on the second year of my Master of Science in Nursing program. And first, I want to thank you for giving me this opportunity to present my thesis project for you. And I would really appreciate it if I can receive your valuable feedback at the end. Before I begin, I need to mention that my study is a scoping review, and we are in the middle of the project right now as we are screening the evidences. However, I try to select some of the valuable evidences to present in this session. These days, we can see that many countries, including low and middle income countries and even high income countries, are facing the nursing shortage. And the global nursing shortage before COVID-19 was almost 5.9 million nurses globally. And for the post-pandemic, this number is projected to increase 7 million. And it's estimated that by the year of 2030, we may need an additional 13 million nurses. And most countries are trying to create a logical pathway for the recruitment of international nurses, and not only for the international nurses, but also for the internationally educated health professional in general. So this approach is more accessible within the high-income countries like Canada and US, because in low and middle-income countries, there are some barriers to international recruitment, for example, poor working conditions or lack of competitive salary. As you can see, we are seeing a significant rise in the recruitment of internationally educated nurses in high-income countries. For example, in Canada, the proportion of IENs has increased from 8% in 2017 to 12% in 2022. And in the UK reports that 40% of new nursing registrants in 2022-23 were internationally educated. And Australia has seen 87% increase in international applications in 2022. Also in the United States, which has the highest number of international nurses among all countries, approximately 500,000 immigrant nurses working in their healthcare system. And based on the statistic that Healthcare Authority in Canada, UK, and US released, IENs coming to the high-income countries are mostly from low and middle-income countries like Philippines, India, and Nigeria as the top three. IENs face different challenges during the recruitment and during the integration into workplace. These challenges can categorize into two main areas. First is system-related challenges, which includes, for example, navigating a credential assessment or adapting to the differences in the nursing practice or understanding the labor market process. And the second is social-related challenges like language and communication barriers, cultural adoption, or building professional relationships, and workplace and team dynamic issues. So these are just some of the examples regarding the challenges which are actually well documented in the literature. And these days, as you know, lots of governments try to ease these challenges by providing an expedite pathway for the recruitment. However, in this study, we are going to look beyond these problems and challenges and to see what types of responses internationally educated nurses show when they integrating into the workplace. There are lots of information on the web about the concept of integration itself, but researchers on the integration and adjustment process says that during the self-regulation process, which is a part of integration process, there could be some potential responses, and responses may manifest in three different domains. First is emotional responses. These are the affective reactions to the stimulus or the event that reflect psychological and even physiological state as well. And the cognitive responses are second. These are the mental process and interpretation that everyone has about themselves in the new concept or new context. For example, self-sabotage or intrusive thoughts regarding the capability. And the last one is the behavioral responses. And these are like the changes in professional performance, such as task avoidance or social withdrawal and development of a specific coping behaviors. For this scoping review, we are adhering to the JBI framework, and based on the PCC framework recommended by the JBI for the scoping review, the population for this study is internationally educated nurses from low and middle income countries. And the concept is the emotional, cognitive, and behavioral responses to workplace integration. And the context is the healthcare system or environment in the high-income countries. And the primary question is, what is known about how internationally educated nurses from low and middle-income countries respond emotionally, cognitively, and behaviorally to workplace integration in high-income countries' healthcare environment? And we also developed two sub-questions that they are going to help us more. First one is, what are the factors that precipitate emotional, cognitive, and behavioral responses among the internationally educated nurses during this process? And the last one is, what are the current gaps in the literature regarding these responses? As I mentioned before, we are conducting a scoping review as it gives us opportunity to explore a broad and complex topic and map and chart the diverse body of the literature. Also, it helps us to clarify the key concept and identify the knowledge gap. For this review, we established the inclusion criteria. We are focusing on IENs from low and middle income countries working in high income countries. And for the country classification, we will use the current World Bank classification. And we will include all ages, genders, and ethnicity and years of experience. And some of the study may have investigated different international educated health professionals together. In such scenario, we are selecting data study that have at least 15% of IENs in their population. We also exclude local nurses, domestic nurses, and international nursing students, and IENs moving between the same country classification because the experience will be completely different. And for the concept, we are examining the emotional, cognitive, and behavioral responses, and we are looking at the triggers as well. And we will exclude responses from personal life event or pre-existing conditions like being a refugee. And for the context, we are focusing on the healthcare environment in high-income countries. This includes all healthcare settings, for example, hospitals, community health centers, or long-term care facilities. For the type of sources, we are considering peer review studies, quantitative, qualitative, and mixed method studies, all types of evidence synthesis and guerrilla literature included as well. We actually developed a comprehensive and targeted strategy for each database with the help of Dr. Melissa Rafos. And as you can see, this is a detailed information regarding the databases we searched and the number of studies we captured. As I mentioned before, we are in the middle of screening process, and that is why it seems like a half Prisma flowchart, and we will complete the chart as we proceed to the next stage. However, so far, we had 9,002 papers from databases and 4,193 as unpublished and gray literature. After removing the duplicate, we have 10,696 papers for this screening. We are two independent reviewers. One is myself, and another person is one of my friends who is internationally educated nurse like me, but she's in Norway doing her master in health. And we will include the third reviewer for two purposes. One is if we can resolve the conflict during the screening process, and also for the quality assurance measures like random checking up for the evidences. And in the final stage for the data presentation format, we are going to present the data in the narrative and tabular format in a way that fits with the research objectives. We also have developed kind of extraction tool, which is modified based on the research objectives in the next slide. This is a draft of extraction tools. It may also change in the next stages to make sure we are extracting what we need. I'm not going to explain all these titles one by one because I think looking at some of the results might be more interesting for this session rather than just reviewing the extraction tools. For the final part of my presentation, I try to extract some of the evidences from potential included study during the title and abstract screening to present for you as a kind of sample of final result and show you what exactly we are looking for. Here you can see the communication and language barrier, which is a well-defined challenge for internationally educated nurses during the workplace integration. And according to what we found in the literature at this moment, this barrier can cause some behavioral, emotional, and cognitive responses. For example, for the behavioral responses in such scenario, when the nurses face this barrier, they try to speak in the native language as a coping mechanism on many occasions. Also, they may leave the stressful situation on purpose. Like when the unit phone is ringing, they try to leave the nursing station to prevent the stressful conditions. For the emotional responses, they report that communication and language barriers as one of the most underlying reasons for the anxiety and stress in the workplace. Also, they have developed some cognitive responses like self-doubt about their ability and something that they refer as a selective attention bias toward the stressor, like focusing excessively on the barriers and overlooking to the potential solution or support. On the top, there are some triggers behind these challenges and responses. First one is unfamiliar accent and use of the slang and idioms. And one interesting point is that I saw some quotes from the participant in some study that their colleagues told them, "You are a hell of a good worker," but they didn't know what types of sentence this can be. Also, they mentioned that using a different jargon or abbreviation may play as a trigger. For example, in UK, they mostly use MBM instead of MPO for the patient. And another one was the physician handwriting, which whoever work in the hospital has similar experience, I guess. And the other trigger was being in an uncomfortable or a stressful situation like shift report or endorsement. The next well-known barrier in workplace was workplace discrimination and racism. There are some triggers for this barrier. For example, not having a safe opportunity to report because of the fear of retaliation, or microaggressive behavior are another trigger. And another interesting point is that according to the research, microaggressive behaviors have greater health risk compared to the overt discriminatory behavior that may be intense but brief and singular. And the other trigger are face gesture and nonverbal cues toward them in the workplace. And at the bottom, looking for the responses which are rooted in the specific barrier with the help of such triggers, we found that there will be some behavior responses like physical withdrawal, for example, tardiness or absenteeism. Also, they make decisions regarding their career, like intention of leaving the nursing profession entirely. Also, there are some emotional responses rooted in this barrier, like vulnerability, powerlessness, intimidation, or humiliation. They also show some cognitive responses like rumination, which means repeatedly replying the discriminatory incidents in their mind, which will probably affect their confidence as well. Also, there was cognitive distortion. For example, they perceive the entire workplace hostile. So this was a kind of general landscape that this study actually intends to work. Actually, we intend to work on it and some example. And I believe we should not pass some of these evidences easily. For example, I was reading a report last week that employee tiredness, specifically tiredness, cost the US organization $3 billion in 2012. And I think that most of the time we just see the number and pass. But for example, to understand this number better, if we spend 10K every month, it takes 25 years to finish $3 million, but it takes 25,000 years to finish $3 billion. So I guess this is the way we should look at these evidences. So this was some of the interim result I personally extracted at this stage. Once again, we are in the middle of a screening process and we have not started the extraction yet. So, however, I believe that the final result can be really interesting and helpful for us to understand these responses better and help us to develop better and targeted intervention in the future study as well, I guess so. And that's it. Thank you so much for listening.
Thank you so much, Peyman. Very interesting presentation. Very well done. Yeah, like hard to believe 2030 is just really not that far away. And
Yeah.
it's scary how what the needs will be. I can just start off with a quick question. I know you're in the midst of your review, so you've only sort of given us a taste of what you're seeing. Anything surprising or what you've seen so far, do you think like, yeah, I can totally see that happening or anything different than what you thought?
Yeah, exactly. At the first steps, I was thinking that maybe all the international educated nurses have only negative feeling and show negative responses. But when I go through the literature and saw evidences, I saw that they have some positive responses as well. And that is why we are looking in this scoping review, we are kind of looking to map all the responses, regardless of being a negative or the positive responses. So that was the one that I was thinking about it, only negative, but the literature showed me that there will be some positive responses as well. And this was one of the interesting points as well.
Excellent, thank you. Does anyone else have any questions for Peyman? Oh, you're getting off easy there, Peyman.
Yeah.
Very good. Awesome. Thank you. All right. So we still have a bit of time, but Morgan, are you okay if you start yours now? And that way, if you have a little bit extra time or you don't need to take additional time, but we'll just start it now if that's okay. Okay.
Yeah, sounds good.
Perfect. So our next presenter is Morgan MacNeil, and Morgan is currently doing her PhD in nursing with us. And the title of her presentation will be Pain Measurement in Infants and Children with and at Risk for Neurological Impairment.
Great. Thank you so much for the introduction. Like Audrey said, I'm in my third year of the PhD program here at Dow, and this work was part of my comprehensive exam requirement in the PhD program, which kind of segues into what my thesis topic is. So it's titled Pain Measurement in Infants and Children at Risk for Neurologic Impairment. So the experience of pain is highly individualized and personal. It's something that we're all going to encounter throughout our lifetime, and even the most vulnerable of our population, being infants, experience pain within a few hours after being born. And this calls for standards of routine neonatal and pediatric care to outline that comprehensive pain assessments must be conducted regularly to lead into proper pain management interventions. And over the last number of decades, there's been a significant amount of research that's been dedicated to measuring pain in neurotypical infants and children. However, there's been a significant lag in the amount of research that's been dedicated to infants and children at risk for neurologic impairment, which is really concerning because there have been numerous studies that have demonstrated that this subgroup of infants and children are at higher risk for pain exposure than neurotypical infants and children. And this increased risk for pain exposure largely comes from invasive diagnostic tests and procedures that are done to this population, having a higher rate of falls and accidental injuries, a limited ability to understand the implications of injuries that they may suffer from, and having lower levels of physical activity. And again, this is concerning because there's lots of literature support outlining negative health outcomes that are associated with early and untreated pain exposure in neurotypical populations. And this is not meant to be a comprehensive list, but some of these negative outcomes include having a heightened pain response at subsequent painful procedures, altered brain development, increased internalizing behaviors, and even the development of chronic pain. So who do I mean when I say at risk for neurologic impairment or diagnosed with neurologic impairment? So this is an umbrella term for infants and children who have chromosomal abnormalities, congenital anomalies, were born extremely preterm, suffered trauma when they were born, have acquired illnesses involving the central nervous system, such as meningitis, or those who were born asphyxiated. So what I wanted to do with this project, again, it was part of the comprehensive exams that I took during my PhD, is I wanted to identify and map out the pain measures that have been used or that are currently being used in this populations of infants and children. And once I identified those, I wanted to discuss the strengths and limitations associated with the pain measures and make recommendations for future practice and research. So the way that I did this is I conducted a single reviewer narrative review using PubMed as my search engine. And those are all of the different keywords that I'm not going to go over in detail that I included in my search. So the results that I found, I had about 25 papers, and they ranged in date from back to 1970 up until 2022. Largely, they came from Europe, and then the remaining came from North America. The majority of the studies were descriptive or observational in nature, one being a feasibility study and one was a scale validation. So after I read through the papers, I organized the results into 4 broad pain measurement categories: self-report, behavioral pain measures, physiological, and neurophysiological. So I'm going to go through each of these primary categories and talk about the strengths and limitations of them in terms of measuring pain in this specific population. Starting with self-report measures, this is often looked at as the gold standard method for assessing pain, but only when it's developmentally appropriate. Of course, we would never ask an infant to describe their pain to us because they can't speak. So only when it's developmentally appropriate, and only if our patients have the intellectual capacity to understand the questions that are being asked or the scale that's being given to them for them to describe how much pain they're experiencing. Self-report is the most used measure among pediatric populations, and it can be achieved through administering different rating scales or just asking open-ended questions to our patients, such as, "Can you describe your pain to me today?" It's not surprising that there have been very limited investigations among persons with neurologic impairment, and even more limited investigations when you confine the search down to children with neurologic impairment. So my search yielded 2 results. The first one was dated back to 1998. So they were the first group to look at, is there any chance that children with varying levels of cognitive impairment can showcase the skills that are required to use a self-report measure of pain, which in this case was the numeric rating scale. And they concluded that about 50% of the children with borderline cognitive impairment and 35% of the children with mild cognitive impairment were able to demonstrate the skills required to use the numeric rating scale. In 2004, this work was built upon by Bonini's group, and they wanted to see if there was any difference in the ability of children with cognitive impairment to use standard methods of self-report that have been developed and validated in neurotypical children, or modified measures such as the cube test, a modified Eland color scale, or modified faces scale. And what they found, unsurprisingly, was that children with cognitive impairment are better able to use these modified skills. The strengths and limitations of self-report measures. Starting first with the strengths, like I said at the beginning of my presentation, the experience of pain is very individualized and personal. The way that we're going to best understand how someone is experiencing pain and what it feels like for them is by asking them. So it provides a very subjective report of the pain experience, and it really promotes autonomy by putting the patient in the driver's seat and allowing them to kind of lead the assessment. There are recognized limitations of this measure. It can be difficult for children to differentiate between the feeling of fear and the feeling of pain. So if they're very fearful of getting an injection and you're asking them about their pain, they may incidentally report on their fear rather than associated pain with the injection. The anchor terms of different self-report scales can also be tricky, especially when you're comparing different pain groups. Asking someone with chronic pain what a 10 out of 10 feels like versus a child with acute pain, those can mean very different things. Like I said, this is only applicable when it's developmentally appropriate, so it's really only suitable for children and up instead of infant populations, of course. And because there was only 2 studies that investigated the self-report measurement with children with cognitive impairment, there's very limited validity and reliability of the self-report measures, and no one has really looked at the self-reportability since 2004. Moving on to behavioral measures. So this encapsulates facial expressions, body movements, and vocalizations such as crying. It's the most commonly used measure among children with neurologic impairment, whereas the self-report was the most used among neurotypical children. And there have been a lot of different pain assessment tools that have been developed for use in neurotypical children or those with an at risk for neurologic impairment that are largely built upon different behavioral indicators of pain. So through my narrative review, I found 15 different papers that looked at behavioral measures in isolation or in combination with other measures such as physiologic measures of pain. 6 of the studies focused on infants, 8 of the studies focused on children, and 1 focused on adolescents. 3 of the studies focused solely on facial expressions and activity, 1 focused only on crying, 3 studies focused on a combination of behavioral measures, and the majority of the studies looked at behavioral measures in combination with physiologic measures. So this is a list of all of the different pain assessment tools that I identified in the papers that I reviewed. So there were 15, which is great. There's a lot of pain assessment tools out there. However, only the ones that are in bolded font have undergone any type of in-depth validity or reliability or feasibility testing. So unless scales are undergoing that type of psychometric testing, drawing conclusions from studies using scales that have not undergone this testing is questionable. And only those scales that have not been crossed out have been specifically been designed for infants and or children with an at risk for neurologic impairment. Strengths of behavioral measures, they give a better overall assessment than physiologic measures, which I'm going to talk about next. And they're a lot more accessible. Largely, they're observational in nature, so you don't need fancy or technically sophisticated equipment to observe facial expressions or listen to cries or assess body movements. But they do have recognized limitations, reaction times being one of them. So a lot of the time when we're looking at whether or not baby has any type of facial grimacing after they have a heel lance, we're looking at a certain window of time after a painful stimulus has been introduced to them. But there are some infants and children under the neurologic impairment umbrella, such as those with Down syndrome or those with Prader-Willi syndrome, that have demonstrated very slowed somatosensory processing time, which doesn't necessarily mean that they're not experiencing pain, they just have delayed reaction to pain. So unless we take reaction time into consideration and use reaction time independent methods, we may be downplaying how much pain they're actually experiencing and potentially undertreat their pain. Atypical behaviors are something that has been discussed in the literature looking at infants and children with or at risk for neurologic impairment. Some children have been found to demonstrate behaviors associated with pain that are not typical among neurotypical populations, like moaning or laughing. So if you were doing a pain assessment on a child and they started laughing, you might think that they're not experiencing pain. And again, it would lead to undertreatment. So it's really important that we're using scales that takes into consideration these atypical or specific pain behaviors for this population. And finally, behavioral measures are at risk for being influenced by confounding factors, such as the age of the child, the diagnosis, severity of illness, and how much pain they've experienced in the past. Moving on to physiologic measures, these are objective measures of pain that are often used in the clinical setting. Heart rate, oxygen saturation, respiratory rate, and skin conductance. A few of these are measures that we use in the clinical setting, whether or not we're actually doing a pain assessment. And of the different physiologic measures in the world of pediatric pain research, the cardiac indices have been the most extensively studied. And unsurprisingly, there's a theme here. There's very limited research looking at physiologic measures that have been used in my population of interest. So through my narrative review, I found 10 studies that looked at physiologic measures in combination with other measures or used in isolation. Most of the studies looked at children. 1 looked at infants, and 1 looked at adolescents. 6 of the studies looked at heart rate, 2 looked at oxygen saturation, 1 looked at skin conductance, 2 looked at biomarkers, and 3 looked at quantitative sensory testing. So like I mentioned on the previous slide or 2 slides ago, the physiologic measures provide a more objective picture of the pain experience, which limits response bias, which can be important. And some studies have shown that there is a potential parallel with the state of distress. So increased physiologic indicators such as a higher heart rate or higher respiratory rate may parallel with increased states of distress. The clinical utility of physiologic measures is also promising. Like I said, in nursing, we measure a lot of these physiologic indicators, whether or not we're actually doing a specific pain assessment. There are a few limitations to physiologic measures, however. They're not supported in the literature as being pain specific. If you think about different emotions that you feel throughout the run of a day, before I presented, I had a super high heart rate, but I wasn't in any type of pain. So that can be affiliated with fear or anxiety or even happiness. There's at risk for being influenced by confounding factors, just like behavioral measures of pain. And literature states that there's no single measure under the physiologic pain measure umbrella that's a direct correlate with the pain experience. And just like our behavioral measures, physiologic measures, particularly quantitative sensory testing, can be limited when we're looking at reaction times in certain subgroups of persons with neurologic impairment. Finally, neurophysiologic measures. This one is a new and emerging field in pediatric pain. Just over the last decade or so, 1 to 2 decades, have we really been incorporating neurophysiologic measures into pediatric pain assessments. And neurophysiologic measures include electroencephalography, event-related potential analysis, functional magnetic resonance imaging, and near-infrared spectroscopy. Among neurotypical populations, which is where this work is focused for the most part, it has shown promise in discriminating pain from no pain among neurotypical pediatric patients as well as adults. And again, there's very limited research among infants and children with at risk for neurologic impairment. I only found 2 studies looking at neurophysiologic measures of pain in this population. One focused just on children, and the other focused on children and adults. So no neurophysiologic studies have looked at infants. The first one was in 2010. They looked at EEG and somatosensory evoked potentials. The second one was 11 years later in 2021. And the findings from these studies complement each other, even though they were using different methods of neurophysiologic assessment. The first study in 2010 found that children with cerebral palsy and cognitive impairment demonstrated enhanced sensitivity to painful stimuli. And the second study found that children with intellectual disability demonstrated increased activation in different areas of the brain when they were exposed to painful venipuncture. Strengths and limitations of these neurophysiologic measures. Unlike the other measures that I've reviewed, neurophysiologic measures give you more of an insight into the mechanisms and processing of pain, which can contribute to a more comprehensive picture and understanding of the pain experience. They're highly objective and sophisticated in their nature, and they show a lot of promise when they're used in combination with other measures that I've gone over. There are recognized limitations, the big one being clinical utility and feasibility. We've not yet reached a place in researching neurophysiologic measures where it's feasible to, every time you do a pain assessment, to incorporate a neurophysiologic measure. And any of you that work on the floor in nursing can understand that. There's also, again, limited research to establish foundational knowledge to kind of pave the way forward for making recommendations for future research and future practice, which is what I'm going to review now. So I've organized these into the different primary measures. So it's going back to self-report, recommendations for research and practice. We only had 2 studies that looked at the self-reportability in children with cognitive impairment. So we need more studies to look at this, because the 2 studies that I did report on did conclude that there is promise and potential that children with neurologic impairment may be able to use self-report measures, but we haven't done anything with self-report in this population since 2004. And if we're going to do more studies, we need to make sure that the scales are reliable and that they're validated, and that if we're modifying the scales, they undergo the same psychometric testing so that we can make conclusions with the results that are strong and backed up by evidence. Moving on to the behavioral measures, similar to the self-report measures, I highlighted all of the different scales that I found for looking at behavioral measures of pain. However, a lot of them haven't undergone any type of psychometric testing, which makes interpretation of results tricky. So we need more studies that focuses on not creating new scales, but fine-tuning the scales that do exist. Also looking at subgroup studies, throughout the presentation, I've been saying infants and children with an risk for neurologic impairment, which is a really big umbrella term. It's a really heterogeneous group. So focusing on having larger studies that focus on one type of diagnoses, so that we're not assuming that if you have any degree or any type of neurologic impairment, that you present the same way when we're looking at pain responsiveness. Because behavioral measures are at high risk for the influence of confounding factors, incorporating contextual measures into our assessment is really important so that we're getting a comprehensive, accurate picture of the pain experience, and trying to stay clear of methods of measurement that are dependent upon reaction time. Very similarly, for physiologic measures, making sure that we're taking into consideration those contextual measures because of confounding variables, and because the literature tells us that we shouldn't just be using physiologic measures on their own anyway, because none are a direct correlate with the pain experience. And finally, neurophysiological measures. We need more studies on infants. We have no idea what's happening in the brains of these little babies if they fall under the neurologic impairment umbrella. So this is a gap that I discovered before I entered the PhD program, and that's where my PhD thesis is going to lie. So I'm very excited about that. Number two, we need more validation studies with neurotypical children. So with these neurophysiologic measures, they're new and exciting, but they still need to be validated with more gold standard methods such as self-report, especially before we kind of move them over into harder to assess populations like those with neurologic impairment, because they may be pre-verbal or nonverbal. More studies to characterize the extent to which these measures may deviate from other measures. So again, using them in combination with behavioral measures or physiologic measures to see how well they correlate with one another to capture the pain experience. And finally, once we create more of a foundational knowledge with these neurophysiologic measures, they can be used for looking at the effectiveness of pain management interventions because they're so comprehensive, which is really exciting for the future of pediatric pain assessment and management. I think that's everything I have to say, so thank you for listening.
Great. Thank you so much, Morgan. What a lovely presentation. Not just the content, the presentation itself was so well done. I do have a question. I'm not surprised by what you said, because even many adults struggle with, reporting pain. Like, for example, in the emergency, we're always asking, how do you rate your pain out of 10? Well, many don't even understand the question, what you're asking them, that rating piece. And as you've mentioned, pain is so subjective, and it's also what their reference point is. So people that have experienced extreme pain will have very different reference points to those who have not. So it's very interesting and such important work that you're doing. I have a question. I'm interested that you are and again, I think you mentioned when you go forward with your thesis work, you're going to focus on infants. But in this case, you focused on infants and children, which to me seem so different. Was that simply because there's so little research that you felt you had to combine the two? Was that kind of the rationale for that?
Yeah, I think too, because the comprehensive exams themselves are so broad, so we kind of picked a broad topic, which is going to help me narrow it down into the infants, because I've clearly highlighted that there's not a lot out there for infants or children, but significantly less for infants. So it sets me up nicely to introduce my thesis work.
Great. So it's a nice segue to that. Perfect. Okay. So just opening it up, any questions, comments for Morgan's presentation? You might have the same effect like Peyman. Yeah.
We've left everyone speechless.
I guess it was so well done that they're like, no, we have no questions. But it's so nice to see the work our students are doing. And I know other students who are on here are also find this such a great experience and exposure, but it really just, it's amazing what our students are doing. And both for you, Peyman and Morgan, like it's just makes me feel very proud of all of you for all the work and you know, the amount of work that you put into this. So thank you very much for being such amazing students in our program. Thank you. Great. So we have extra time on our day because everyone was so efficient with their presentations. Julie, did you want to say something real quick?
I was just going to say, I put a link into a survey. If anyone could fill it in about how we're doing, what you want from the series, what was good, what was bad for the presenters and the audience as well. And we'd appreciate all feedback.
Yeah.
And now I'll stop recording.
Great. Thank you again, everyone. And Peyman and Morgan for presenting. Have a great rest of your day. Enjoy the sun, but very cold weather. Thanks. Bye-bye, everyone.